So today I'm going to talk about a project that I think is kind of a fun presentation. There's a little bit less of the modeling aspects, and it's kind of talking about, I think, more broadly of the role that integrated healthcare systems can have in public health efforts in general. And so we're going to be talking about the development and use of a text and web-based monitoring of adverse event system following COVID-19 vaccination, affectionately called the Kaiser Permanente side effect monitor. So as a disclosure, as Katya said, I have worked with Pfizer for other COVID work. So when new vaccines come out, we need to evaluate the safety. This is done in clinical trials, but clinical trials can be small, and they often have select groups that they pick to enter into a clinical trial. So we really have to continue that monitoring of vaccine safety even after a vaccine hits the market. One of the probably longest standing and kind of well-known systems is the National VAERS system. It's a system where clinicians principally upload, I think patients can as well. It's very complicated though. When there is an adverse event that's thought to be associated with a vaccine, several forms have to be filled out, and those are added up into the system. So while patients can participate, it's a bit of a barrier just given the complexity. And these systems, often because of the difficulties in reporting and the time needed, are often not representative of the overall population that may be having adverse events. You can't really calculate rates because we don't have denominator data, as it's kind of a volunteer system. There's probably there's definitely substantial underreporting of mild symptoms, again, because it is quite a task to upload. And there's no linkage to patient records, meaning somebody could upload that there was an adverse event, but we don't really know how that impacted a healthcare system or even the outcomes of what happened. So in response to this, when COVID vaccines first came out, we know there was a lot of concern about safety. This was a new technology, a new vaccine kind of formulation, and it's really important to gather real-time safety data on these new vaccines. So probably all of us, hopefully, have heard of CDC's vSafe. vSafe was developed to address some of these limitations of the VAERS symptoms. It's pretty simple and easy to use. You are sent regular reminders to report mild symptoms, and they go right to your phone. However, there are still some limitations to the vSafe system. So vSafe, because it is a opt-in system, we can't really assess representativeness of the population. So for example, of all of those vaccinated, only a small proportion are going to sign up, but we don't really know a lot about who's signing up. I do think they collect some data, but it is difficult to know what the denominator is again. For that reason, it's difficult to calculate rates. They also set it up so that a smartphone or internet access is required, which can limit access to populations that may not have either of those resources. And then there's no linkage to patient records again, which can impact our ability to understand what happened after. Somebody may report that they had a symptom, but they may not have sought care. And that's kind of an important nuance that I touch on a couple times in this talk. So actually with the CDC and members of the vSafe team, we developed another system called the KP side effect monitor. We wanted to make this very similar to vSafe as much as possible so that we would have that parallel comparison, but with some of the added benefits that vSafe does not have. So the KP-SEM is kind of what the short KP-SEM, so I'll probably refer to it that way. KP-SEM does not require a smartphone or internet access because we also contact people just through basic text messaging, and they can interact with the system just using text. And actually, we found that to be a really popular choice for interaction with the system. we do have the ability to link with clinical data. So because this system is being built within a healthcare organization, we can see, for example, if this patient, reports symptoms, reports that they sought care, and then we can look and see if they really did seek care and what did they seek care for and what happened. So I have an example of that we'll talk about. And then we can understand participation against a true denominator, meaning that we know how many people are vaccinated within our system. We know how many people were sent invites for this system, and then we know how many people participated from that. So that's a really important insight to understanding what kinds of biases can be introduced through digital health tools. I think this is a huge kind of big part of public health's future are these digital tools, and we really do need to understand a lot about how they work, how people interact with them, and kind of that human behavior aspect, I think, to be able to use them appropriately. We're able to display aggregate results in real time to staff. So when we have things up and running and things are smooth, we have attempted to automate this system as much as humanly possible. So there's the least amount of manual labor. Data will come in, be presented. I have to admit, this has been harder than we anticipated. The amount of data coming in, the complexity of the data is quite substantial, but we are really getting towards sort of real time. You can picture like a Tableau report or a dashboard that can be shared with staff. And that is really important, again, for the behavior in the clinics of staff knowing about the system, encouraging people to sign up, et cetera. And so it is, we know from a lot of, health behavior studies that feedback can also really contribute positively to participation and stuff like that. We also, a pretty substantial benefit is that this is being offered through KP, which is the patient's trusted health system. We've heard from, I have many friends having gone through EIS, for example, that are working in public health departments. And have sort of, we've talked about, when the health departments were kind of cold calling patients and trying to get them to sign up for things or talk about their COVID or provide contacts, people are a little skeptical. And, sometimes people may not want to participate in government programs or things like that. But I think by offering this through a known partner in health, we were hoping that we would get higher participation rates, which we do. So I think that's also a benefit of the system. So again, this is in collaboration with the CDC. This is funded by the CDC, and this is happening through a consortium called the Vaccine Safety Data Link. The Vaccine Safety Data Link has already been going for, I think, decades, and it's a consortium of these health institutions shown here, and this network evaluates vaccine safety in real time. We tend to use other systems, not this sort of self-report digital tool, but this was sort of a new direction that the VSD wanted to invest in, the Vaccine Safety Data Link, because again, there's probably a lot of utility in the future if we can kind of work out the complications of the logistics. So in green, that's where I sit, Kaiser Permanente, Southern California. I'm in Pasadena. And then there are several other Kaiser Permanente VSD sites that we are hoping to expand this system to. There's a lot of shared sort of IT background between Kaiser Permanente sites. Unfortunately, there's also some uniqueness to each place, but we're trying to work through that now. So this pilot study, which is just KPSC that I'm talking about now, because we have not yet expanded, that's just Kaiser Permanente, Southern California. And here we have about 4.7 million members. So it's quite a large population. I could literally talk about this slide for 3 hours. I won't. It's been, and I'm not even exaggerating, I think this is one of the hardest projects I've ever worked on. And it's because of the number of different stakeholders, the number of different groups that have not participated with research. I think sometimes, we take it for granted sort of how things work and what the expectations are, but it's been really a lot. And then also with KP leadership, just, getting leadership approvals at the highest levels, having everybody in the know. We can't have certain leaders unaware of the system and be caught off guard. There's a ton of legal implications of launching something like this to an entire KP membership. If you think about it, anybody getting vaccinated is getting invited. So they have to, it has to be a very careful calibration of what the patient sees. There's a ton of branding that goes on. Like I said, there's a lot of legal around, for example, one example is just the disabilities, making sure it's compliant. And then on the back end IT side, just a lot. And the KPI, will just leave in my last comment at the KPIT team. They're also dealing with all of the IT for all of Kaiser Permanente. It's a lot of IT. There's a lot of emergencies. There's a lot of very urgent situations that we've had to navigate where they couldn't, for example, work on this project because they have a major data breach, not breach, but a major data issue that they need to address in order for KP to run smoothly. And so it's been a lot of that. And I do think as an epidemiologist, this is one of the first times I've worked in a situation like this. It's been very unique. Typically, I just kind of access the data, the electronic health records, and I'm very familiar with that, but this has been new territory, but very powerful. So just wanted to point that out, that research can go in a lot of different directions. So we have posters where we allow for in-facility recruitment through a QR code. So these are posters that we made for this study, and they go up in the vaccine administration centers. So basically KP had set up these huge halls, in addition to clinics, where people would go get vaccinated en masse. So these were just like large vaccination sites. So we went and put up posters so they could, and they also got flyers at the time of their vaccination. They would get a flyer with this on it, and they could join the system through a QR code. And we designed the system to allow patients to join almost entirely remotely so that there really is no staff involvement. Something of this scale, we really can't have staff involvement. We need this to be like a totally self-sufficient system. So the posters also we developed in Mandarin. We have a large Mandarin speaking population and a very large Spanish speaking population. So everything is available in Mandarin and Spanish as well. So there's also digital recruitment. If patients don't sign up in the clinic, the next day we send out active digital invites that take them to a sign up page. They can receive these through text, email, or message center. So message center, I didn't really go into detail, but that's like a secure messaging system where it like comes through kp.org and they have to sign in order. So that's the highest level of security for those that really don't feel comfortable interacting without a sign-in through to a known kp.org site. And then we would send them these based on the preferences they had in their files. So pretty cool customization there, and their digital communication history on file, what they liked. Most of the active digital invites did go out through the kp.org message center. We found that I think that feeling of security was something that helped. If they did not reply right away, they received a reminder invitation through an alternative channel. So we would then switch it up, which mode they got, and they would get another invite 24 hours later. After 2 attempts, just based on law, we don't contact them again. To sign up for themselves, you can see it at the bottom there. You have to be 18 years or older. Once the vaccines, the mRNA vaccines were available for children, we added the dependent button so that parents or guardians can sign up on behalf of a child. So I don't go through all the pages, but this is kind of a consolidated version of the different question pages that a patient would get. So these surveys are sent out. So each box here is one of the surveys, and then you would kind of click through them. So the surveys are sent out every day for the first week and every other day for the second week after each dose. Again, we really wanted to align this with DSafe so that we could compare, use it as a bit of a mirror. So since your vaccination, have you experienced any of the symptoms at the injection site? So the first one is really about injection site symptoms, and then it goes more into systemic adverse events. Over time, oh, another benefit of this system is that it's what's the word? It's adaptable. So we can add things, take things away as needed very, very easily, like probably within 24 hours. So for example, menstrual changes was something that, you know, you probably saw in the news that came up at people talking about different menstrual changes after vaccination. So that was something we added here. The cardiac became a really big deal. So we have we added some questions about cardiac adverse events, and that's been a really nice aspect of the system, is just how quickly you can change it. And then we ask if they sought care for any of these symptoms, and then we say thank you, and basically also we say this is for reporting purposes only, and you know, if you have a problem, you need to seek care. It's an important part of research, especially within a healthcare system. We don't want people to think that by reporting here that their doctor is getting that, because they're not. And that was something we had a lot of discussions about too. So for weeks 3 to 5, patients receive the surveys weekly. So just the systemic questions. This is the sort of when we were really just launching and piloting, we were going to see what the places look like. So, so Debbie is in the middle. She's my current EIS officer. I'm on the left, and one of our team RAs is on the right. She's been awesome. So this is the pilot site implementation and launch. So here we went just to talk to the staff about what this system is. We provided the patient handouts, we hung up some posters, and we just kind of wanted to see what the sites looked like. At the picture at the bottom, I think this was a bit of an issue, is you can, they had a lot of papers. I'm just looking, I see a vSafe flyer. So we removed all of that. Might be a question that some of you are thinking. How do you do this with vSafe being national? Because we worked with CDC, CDC allowed us to remove all vSafe invitations, so that we would only have the KP-SEM, and it would be less confusing for patients, because if they have more than one system, it would be very confusing. So for example, you can see those vSafe flyers, those were removed, but there was very little space on the table for all the flyers we had. We had to provide English, Spanish, etc. But it was really nice to be able to go to the sites and get feedback mostly. So these are sort of some preliminary results from the system. So we had over 1 million people vaccinated at KPSC facilities, and 80% of these were sent a digital invitation. There's various reasons why that 22% is missing. Sometimes there were just digital, basically KPIT issues in the background, or not getting it up and running once people started being vaccinated. That's part of it, but 80% is really high. And individuals were invited digitally if their contact information was on record. So most invited people are KP members, but we did have non-KP members get vaccinated at KP, and they could also join through the QR code. We wouldn't have the healthcare information, but they still could join the system and report symptoms. So participation was high among the invited population. About 16% of those invited completed at least one survey. That may seem low, but that's actually quite high. These types of systems, there were several systems that were kind of launched to evaluate either COVID symptoms. I saw a couple papers on that, or COVID vaccine symptoms. And they were usually typically between 5 to 10%. And in those symptoms, again, you didn't really have a denominator. And so sometimes the populations would look kind of homogeneous. And we can see here kind of a little bit of that trend peeking through even in our data. This to me is really, really important. I mean, regardless of what we find in terms of adverse events from vaccination, I think it's really important, this tool to me, is just to understand interactions with digital tools and representativeness. And I think that can help us in a lot of ways moving forward. So what we see is that participation was higher for certain age groups, those white and women. That's what's seen in a lot of systems where the majority of the responding population is actually kind of fits those demographics. We did have really high, though, participation from other groups, and we have a very diverse population. So we do get a lot of diversity that I think a lot of the other systems don't get. And I just think it's a great insight to have. So these next couple of slides are just an example of how this tool could be used. And this is a study that we did looking at children aged 5 to 11. This study was kind of considered a priority by CDC, our partners, as there's not a ton of vaccine safety data in this younger age group. Certainly not a lot around myocarditis and some of the cardiac events that have been of concern, particularly among adolescents. And also, we know that vaccination rates in this age group are pretty low. So could be due to concerns about safety. I think there are a lot of concerns about parents about the safety of these vaccines in their children. And so I think the more evidence we have about either way, however it pans out, is really helpful to help people make decisions about vaccination as opposed to more unsubstantiated just decisions based on I don't know, other non-rigorous sources. So, you know, clinical trial data showed the vaccine was safe. VAERS has shown it's safe, but again, you know, who reports to VAERS? And VSafe also confirmed a pretty good safety profile. But I have to say that this VSafe reference, the MMWR, they had about, I don't know what the exact participation rate is overall, but they had about 45,000 respondents. But then when I was looking on the CDC website to see, well, how many kids of this age group have been vaccinated, maybe there's a little discrepancy in the time period that they were looking and the time period today that I was looking, but it seemed like about 10 million. So that's a very low participation rate. So I'm partners with the VSafe people. I don't mean to insult their system, but I think that their participation rate has been low in this age group. So I think as many sources that we have, the better. As the more data, the better, right? Okay, so this was parents and guardians, and we also used the electronic health records to sort of follow up on some of our findings. This was members 5 to 11. We looked at outcomes in the 0 to 7 days following vaccination, and our study period that we focused on was November to December of last year. And we just really wanted to look at reactogenicity reported through KP-SEM, and then take a slightly deeper dive into medical encounters documented in the EMR, and particularly those with higher acuity, higher severity, principally hospital visits. So of 50,000 eligible children that were vaccinated, about 12% completed at least one survey within 7 days of vaccination. You can see that participation rate was highest for the younger age groups. Also, another thing that I think we're trying to understand is why dose 2 seems to be lower in terms of participation compared with dose 1, but that's what we've seen so far. I think we probably have some data digging to do, or it might just be the way it is. Let's see. Okay. Here, we can see again that participation was higher for parents or guardians of white children. So something that I think is, you know, really important to keep in mind, but pretty high participation rates for the other groups compared to what we've seen so far in terms of digital health tools. So some pluses, some minuses, but you know, we have to keep trying with new technologies. So local or systemic reactions were reported in at least 1/3 of all respondents. It looks like higher with dose 1 for local reactions, and then slightly higher for systemic with dose 2. And the most commonly reported local reaction was pain around the injection site. And then most commonly for systemic was tiredness, fatigue, headache, joint body pain. This is a little bit different than I think some studies have shown, where dose 2 reactogenicity seems higher. This may have to do with the fact that we have lower participation for dose 2, or other things. Could also be, I think, a little bit around behavior, where it's possible that when, you know, a patient will get a response to dose 1, and then, you know, typically self-resolves, and then by dose 2, maybe they're less concerned about reporting. I think it's something we need to think further about. So again, tachycardia or chest pain or anything about myocarditis was a very high priority for CDC. I think that's one of their biggest questions about the pediatric safety. So that was something we sort of dove into. Around 1% reported tachycardia or chest pain, so rapid heart rate, and about 6% reported other symptoms. We did leave that option for other symptoms to capture any symptoms that were not covered in the pre-selected list. And then we, you know, because we can link back to the electronic health record, we can get a sense of those. vSafe, I think, did have a free text field to put that, but in speaking with some of the leaders around vSafe, it was a very difficult, you can all imagine being data people, from a data perspective, to organize those data. And so this is, you know, potentially another approach that could work. So about 6% reported other symptoms. And also it's a chance to, you know, we have our pre-selected symptoms, but maybe there are other things that we don't know about, safety signals from these vaccines that a system like this could pick up, which is really important. So tachycardia and chest pain. So about 1% reported tachycardia or chest pain in the week following vaccination. So of about 6,000 vaccinated, there were 32 reports of tachycardia or chest pain. 11 reported seeking care through the system. So remember that question about, did you seek care? 8 of those had a documented medical encounter. So a good proportion, but not all. And it's possible people seek care outside the system, although we are a prepaid system. So people in the Kaiser Permanente system do tend to seek care within Kaiser Permanente. And 3 had a hospital visit. So we were able to do chart review on these 3 with a hospital visit, and found that primary diagnoses were not associated with chest pain or tachycardia. Only 2 appeared possibly, but not likely to be associated with the vaccine. Those are the 2 in red. But there were complaints about nonspecific nausea, vomiting, and abdominal pain. So it is possible. So not too much though about the cardiac symptoms. For dose 2 of those vaccinated, I won't go one by one, but in the end, we had 0 with a documented medical encounter. So useful to know. And I think also another thing that we need to dive more into is, of the 50 reports of tachycardia or chest pain, we only have 1 reported seeking care. So I think that's something that we also are pursuing. Just for other symptoms, of those 7% and 5.6% reported other symptoms after dose 1 and dose 2. So of those that reported other symptoms, 44 sought care, 29 had a documented encounter, and 2 involved a hospital visit, and that was for UTI and acute pharyngitis. So probably not likely to be associated with vaccination. And for dose 2, there were 2 hospital visits, appendicitis and laryngitis, also probably not associated with vaccination. So for those that reported seeking medical care, about 1% reported seeking medical care following dose 1 and 2. So this is just looking at it from a slightly different angle as opposed to looking at it from a symptoms perspective. 2 were possibly associated with the vaccine, again, sort of the non-specific symptoms. And then for dose 2, some non-specific abdominal pain, so possibly associated. And for the possibly associated in all of the chart reviews, we had a couple clinicians on the study that are making the determinations. At times it can be difficult because a physician may not state their position on whether it's vaccine associated or not. So, you know, from a conservative point of view, I think non-specific symptoms in general are possibly considered to be possibly associated. So limitations of the study, there's no control population. So we don't know what the baseline rate of these conditions are. That would be really helpful, for example, in the unvaccinated, but we don't have that here. It's, you know, the representativeness is a question. Are those that potentially are more likely to have adverse events also less likely to participate? It's possible, and that's a limitation of this tool. We're possibly missing encounters if patients seek care outside the system, although again, that's probably unlikely. We have limited sample size, particularly following dose 2, and short duration of follow-up. So conclusions from that are local and systemic reactions are common within 7 days, but in most cases, these reactions did not result in medical follow-up, which I think is a really important point. I think for something like VSafe, when they report adverse events, that's kind of where the information ends. We don't have a sense of whether that led to a medical visit, like which can be a sign of acuity and severity and concern, and then also how it, you know, how things ended up. So I think, you know, VSafe is very useful. It's obviously much broader in terms of reach, but I think the reporting of symptoms, you know, may have limitations. And then for those reporting chest pain or tachycardia, we didn't see a lot of healthcare seeking for those symptoms, which is great, because again, that is a big concern around pediatric vaccines. I think generally about KP-SEM, to me, one of the most important things is insight into digital health tools to better understand representativeness, and also kind of the gaps between reporting and healthcare seeking behavior, so we can understand the tools better that don't link to an electronic health record, and think about where those gaps might be. I also think building up this system and kind of coordinating this many different groups within our organization has been a useful learning tool. I think it's been a great partnership with CDC. In terms of, again, how can integrated healthcare systems or other healthcare systems have a really big public health role? I think that became much more apparent during COVID, but I think it's still not quite there. CDC tends to sort of set up their own surveillance systems, but, you know, we have a lot of data. We should partner and you know, try to get to our goals together. Does have the potential to identify rare adverse events with the, you know, the other symptoms, things that we're not including on our pre-specified list. I think we can improve adverse event estimates, again, you know, given the limitations of VSafe, and to really understand the true burden of those adverse events. You know, there's still a burden if somebody has an adverse event and they miss a day of work, but they don't seek care. I certainly do not discount that, but I think it is another piece of information to understand, did these people even go back to a clinic because of their concerns about a vaccine? That's really important when we have new vaccines hit the market that don't have a ton of data on their safety, or only data from clinical trials, which again, we know are very limited. And next steps are, we're working on a manuscript. I think I would like to kind of, we have focused on severe healthcare encounters, but I think it'd be nice to look at some of the more ambulatory healthcare events, expand to other KP sites, which is something we're kind of in the process of. And then long-term dream would be to use this for other new vaccines. I think we need kind of real-time vaccine safety in as many ways as possible. Debbie was so instrumental in this project. She's, again, my EIS officer. She's put a ton of heart and soul into this. We all have. It's just a very large, this slide does not include half the people. So, but these are some of the people that have helped.